Okay, good morning. My name is Jean Fajadet, and I have really the chance to share this important session on renal denervation with Ibrahim Al-Rashdam. And I would like to thank all the panel with Aref Al-Noyani, Fahad Bazleh, Aref, Mohammad, Sandos is here. And why it's important? Because the reduction, the lowering of blood pressure, and the effect of to lower the systolic blood pressure is really a major point on the clinical outcome of the patient with hypertension. And this was perfectly demonstrated by a paper, and you could come back on this paper, in the Lancet in 2016 by Dana et al. And they demonstrate clearly from a meta-analysis of 120 studies. You know, it's a huge number of studies, and they look at the effect of the blood pressure lowering on the clinical outcome. And there was definitely a significant reduction on the cardiovascular disease, the mortality, the stroke rate, and heart failure rate. So definitely it's demonstrated. And second point, what was demonstrated, it's not necessary to reduce your systolic blood pressure from for 30, 40, 60 millimeter mercury. Absolutely. If we reduce by 10 to 15 millimeter the systolic blood pressure, you will have this strong effect. So that is important because now we will see during this session, we have some recommendation from the major society. We have some reimbursement in some country, particularly in Europe now we have. And so it's time to open, to prepare, and to open what I will see center of excellence on the treatment of hypertension. Why I say that? Because today the technology is simple. We will see that this morning. No complication, close zero. It's just the femoral puncture, like a standard angiography. The effect is there, demonstrate. And we have now the recommendation. So now it's time, in the same story that we have with the structural disease with the first TAVI. At the beginning of the TAVI procedure, we did some TAVI, one TAVI in some center, and now we have center of excellence. And, you know, it's a matter of organization to structure the treatment of the patient with hypertension. And I'm sure that the outcome in the next month and the following years will be really impressive. We cannot imagine what we are doing today in our center and what will be if we structure the way to, you know, receive the patient with hypertension, have a discussion with some specialists in the center, and then deliver the treatment which is really simple to deliver and efficient. I think that there will be a promising evolution for this technology. So I don't want to be long. Maybe we could have the first slide and to look at the objective of the session. First is to understand which patient to select for renal denervation. Based on the clinical evidence, we will see that, the consensus and the current guidelines. The second is to learn how to perform this procedure, which is based on ultrasound effect, and how to build a renal denervation program. And finally, to understand the future direction. And this will be important to understand that. It's not only to reduce the blood pressure. You will see the future of this technology. So I think that, Ibrahim, you can present our speakers.
So I guess nothing is better than starting with people who had experience in the region with the technology of ultrasound-based renal denervation. I start with Dr. Mohammed Al-Mohammadi, who's going to discuss with us which patient to choose for ultrasound renal denervation and overview of the guidelines and a case presentation from his center. Dr. Mohammed?
Right. So you know, just before you start, you know here in the forum, how does it work? Do not hesitate. We are here to answer to your question. If I cannot answer, I will tell you honestly, I don't know. But we are here, all of us, to answer to your question. So, following the presentation, we have a stop, and I invite you to ask your question. Second, there are never stupid questions, okay? If you don't know the technology, say, I don't know the technology, no problem. Okay? We go. Please.
Great. Thank you so much, and thanks for the invite. My name is Mohammed Al-Mohammadi, interventional cardiologist from Saudi Arabia. I like the term that it's not renal denervation procedure, it's more of a renal denervation program. And I think if you are looking to establish that, I think focusing on the whole picture of renal denervation is more important than the procedure itself. Obviously, the conflict of interest that this forum is sponsored by RECOR. So why we're gathering here today? Because we recognize there is a significant issue that we need to deal with. We talk about a lot about dyslipidemia. We talk a lot about motor vehicle accidents. We talk a lot about coronary vascular disease. But I think in my eyes, the driver for most of the cardiovascular events is actually the master of them all, which is the high blood pressure. And that's affecting almost 30% of the global population. And I think in our area specifically, it's way more than that. In addition to that, the patient adherence to medication, we know it's a nightmare, and especially in young population who are basically busy with their own lives and not taking care of themselves properly. And the compliance usually falls into 50%. And adds to that, in patients with resistance hypertension, you're almost reaching 80% of non-compliance when the medication is up to six medications. So these patients actually suffer from taking these medications with all the side effects, as well as the hypertension itself with all the side effects comes with it. So what are the clinical evidence? And I think we like to be evidence-driven, and this is kind of a very important slide to show how rich the data has been regarding the technology. And it goes back almost a decade. So main foundational study would be the Radiance 2 and the Radiance Solo and the Trio. And these tested different patients off and on medications. Some patients, a couple of the studies were in the mild to moderate hypertension, but the Trio kind of pushed the margin with the resistance hypertension. And there are active programs to continue validating these data and checking the real-world registry, including the Global Paradise System. There are also supporting studies, but the whole idea here is basically to have an overlook about all the evidence there. So the main clinical trials were designed, which is randomized trials, basically started with a Solo, followed by the Radiance 2 and mild to moderate hypertension, some of them controlled and some of them not controlled on two or less medications. And the resistance hypertension, which is the Trio, and that's the one kind of pushed the technology further and got the FDA approval for a lot of patients. And the blood pressure in the Trio trial is basically more than 140/90 on a 3+ antihypertensive medications. These patients were randomized between the ultrasound RDN and the sham procedure. And in all the three trials, basically, it was clinically significant or statistically significant difference between the two. And in this group of patients, even the non-responders to RDN were included. So the difference was significant, having the non-responders as well. But if we took the responders to the technology, basically you can see a significant drop in the blood pressure, more than 10 millimeter mercury, and in the resistance hypertension almost reaching 20. So this is the pooled analysis for all of them in the 24-hour blood pressure monitoring, and we can see the significant drop, especially during the nighttime for these patients, and how it's effective and has been sustained. Talking about sustainability, so whatever you're going to have in 6 months, most likely you're going to have it at 2 years. And this is what the slide shows, basically, that the long-term sustainability of the reduction of the blood pressure has been proven throughout the first 2 years. And usually the end results shows up around 6 months post-procedure. So this is about the pooled analysis. As we mentioned, that the Paradise ultrasound RDN demonstrated sustained around 15, almost to 20 over 24 months in patients with uncontrolled hypertension with an excellent safety throughout the 2 years. The ACHIEVE study basically focusing on the solo, and that followed these patients even further up to 8 years, and we can see here in the 24-hour and the office blood pressure reaching 20 and sustaining 20 in 8 years has been demonstrated. So 6 months real world registry. So we know that clinical trial is a setting, and the real world is a completely different settings. And we always like to see the real world data, and it does indeed show that even in the real world registry, that in 6 months the drop in the blood pressure post procedure reaching 20 millimeter mercury, and the initial look of this demonstrated that at 6 months, the positive safety profile, especially with the high-risk patients population, that's reinforcing the pivotal trial findings. We know, for example, the clinical trial of a SPRINT trial, in 2 years, it's completely falls apart in the real-world data because you cannot sustain that setting. However, in this situation, the setting in the real-world data has been demonstrated very nicely. Safety profile, as it was mentioned earlier, it's a fairly safe procedure, and this is what makes it very attractable for most of the centers to start establishing these programs. So how the guidelines basically adopted these findings. So all guidelines across the board put RDN as a class 2B indications as an adjacent therapy. The initial trials of meds, maybe that fell out of favor. So what we know now that we keep the patient in medications or de-escalate some of the medications, but they need to be in some, and the renal denervation basically can be an adjacent option for these patients. So if we go through the European Society of Hypertension clinical trials, we see here that if the patient has a GFR more than 40, an additional treatment for resistant hypertension would be considered class 2B indications. Grantedly, as a class 1C, that it should be a shared decision between the patient and the physician, as well as it should be performed in an experienced center to get the best outcome. ASC guidelines highlighted very nice that in patients also with increased cardiovascular risk, maybe you want to kind of be proactive in these patients and consider this, despite being 2PA. But I think in these patients, I think they deserve a closer look in terms of offering the therapy to them in order to decrease their outcome. So who's the ideal patient? So after doing plenty of procedures, I think we see the patients who are on 7 medications and with a blood pressure of 200. Is that the ideal patients? This patient deserve an RDN, but I think the true ideal patients, based on what we saw and based on how we talk with our colleagues, is the patients who are on 4 medications with a blood pressure hovering around 150 or 160. These patients will get the most, but usually, unfortunately, these patients do not get referred easily. So that's a more education to our primary care physicians and our nephrologists to start looking at these patients. If I want to leave with one message I want to deliver to the audiences here would be this slide, is don't underestimate the power of 10. A drop in 10 millimeter mercury can actually decrease major cardiovascular events by 20%. So sometimes if we go from 160 to 150, we say, we didn't do much, but no, you actually did a lot in terms of decreasing the cardiovascular events down the road to your patients. So I'm going to show you a case, and this case is basically just to demonstrate another point that I think many of us have a question. She's a 48-year-old female. Her blood pressure initially was 160 over 106 medications. So I did an RDN for her last year with a different platform. And then the blood pressure was still high on the same meds, and we were wondering, can we redo for these patients? So I brought her with the ultrasound therapy RDN, and actually the blood pressure post procedure 2 months after the procedure was less than 140 over 90 and 4 meds. And this kind of answered the question for the people who are hesitant to consider redo in some of these patients. I think it's safe. I've tried it twice in a couple of the patients, and it worked very nicely. Maybe it's just kind of complementing each other, or one device delivering more therapy. With that, I would like to thank you so much.
Thank you, Dr. Mohammed, for reviewing all the data with the sham control trials. Quite convincing, and nice that it translated to the guidelines 2B in most of the guidelines. So any questions?
Any question?
Yes, please.
2 points here. Oops. 2 points here. I think it's still early to compare the two techniques, the two platforms, ultrasound and RF. This is one point. And the second point is the pain during the procedure. Before you use the other platform, it's so painful. The patient needs a lot of sedation. You start with conscious sedation. Sometimes you need to go for deep sedation with EATS, RF ablation, severe pain. So what's your experience in the ultrasound?
Yeah, a good question, because that was my initial question, because we know severe pain can lead to more medications, and more sedation can lead to complication as well. So the pain is less. There will be pain, so the patient needs to understand there will be pain, there will be some sedation, but it's less in two ways. I think the severity of the pain is less, but also the frequency. With the RF, you need to ablate multiple times in multiple branches. However, here you're not going to exceed 3 therapies in the main renal artery. So the frequency and the intensity are a little bit less, but the patient needs to understand there will be some pain into it, and they would require some sedation, yes.
So
Other question?
you have all the operators of the technology in the region, I guess. Ahmed, Sondus.
We can also, in the second presentation, we're going to touch exactly how many seconds you're going to have the pain. Yeah. So when I'm going to talk.
It's like having your radial needle, like patient says, hopefully. But I was talking to Ahmed, there's more than just a short it's maybe a little bit prolonged
Yeah, so I do want to steal the thunder of my colleague, so I would leave that point to how many seconds.
Regarding patient selection, most of the CKD patients have resistance hypertension and require more than 4 drugs. So you have told that creatinine clearance more than 40 is required for the RDN. Can you go below creatinine clearance less than 40? Can you go for the renal therapy, or normal renal function will be better than the CKD patients with the RDN?
Yeah, it's an excellent question. I'll be honest. Like before the session, I was called by my colleague who's asking the patient needs RDN, but the creatinine 350, GFR 20. So I told him I wouldn't be able to do it. However, I think learning the technology and pushing the limits is something as a learning curve for all of us, and our comfort zone going to get wider and wider. But maybe that's a question to everyone. So what is, the recommendation is don't go below 40, but from real practice, would anyone do it in a GFR of 25 or 30?
That is because you need to contrast.
Yeah, the contrast, obviously.
So basically, it's a contrast issue. Yeah. Not the technology issue. Yeah,
absolutely. And if you push the patient toward dialysis, good luck managing hypertension in a dialysis patient. That would be more nightmare. Yeah.
Yes, please. Ahmad.
Yeah, the contrast is a good concern, but with renal angiogram, you can do it with CO2. And that gives you a real good DSA or using CO2 contrast rather than iodinated contrast.
Yeah, 100%.
So you can eliminate the use of contrast.
Yeah, absolutely.
Completely.
Absolutely, 100%. Again, I think meeting next year, we're going to start talking about pushing the limits. But, you don't want to have many issues, especially in starting programs or the first 20 to 30 cases.
I guess
Ibrahim,
that's a very important point Dr. Mohammed is mentioning, is that, you don't want to do all the crazy stuff in the beginning. I mean, we learned whenever you start doing the crazy stuff in the beginning, that's the asking to fail, So stick with the guidelines, with the recommended.
I think so. A good example of that is DCP. When we saw dissection at the beginning, we stent, but now we see dissection, we say that's going to be fine. I think RDN is following the same path. I think the easiness of this technology going to make us adapt it quite broadly, and I think we're going to start seeing pushing the limits very soon.
Yes. Yes, please. 1 second, we have to give you a microphone. We'll take it from you and next.
thank you. What about the anatomy? It's recommended to do CT angio or ultrasound before, so if there is any anomalous about the renal artery.
100% excellent question, because I did have a case that did not know the anatomy and ended up there is no left renal artery, but I found that in the cath lab. So in the clinical trials, some imagings were done, but is it practical in the real world? No. Most of our patients come from the nephrology department, so they do have some sort of imaging, but I think ultrasound kidney at least, if possible. Otherwise, you can just pigtail injection and you see what you get.
What about the size of the kidneys? Affect the procedure per se, or it's inclusion or exclusion criteria? If there is any change in the size of the kidney?
The size of the kidney itself or the renal artery? I'm not aware of size of the kidney issues. It's mainly about the size of the renal artery, correct?
I think we need to move to the next speaker, and all the questions will be answered. Can we?
Just this
Okay,
one. Yeah.
What about exclusion of secondary causes of hypertension, mostly hyperaldosteronism?
Yeah, that goes without saying. These patients who should be offered the therapy, secondary hypertension, should be excluded beforehand.
Just a comment. Thank you for this really great presentation. I was really impressed by the result of this technology, but I was impressed by your first slide, this one.
Yeah.
And this one, personally, I didn't realize the impact of hypertension, which is the main cause of disease burden. In other words, as interventional cardiology, we talk all the time about diabetic, etc., renal failure, etc. When you look at this slide, it's really happened like what we call a silent killer. And this is really impressive for me to realize that definitely we need something to do.
Yeah, and we need more teaching and outreaching programs to the primary care physician, to the community, that there are options for these patients, so we should not leave them alone.
Okay, we have to thank you. Ibrahim, we can move to the...
Sundus Samarkandi is going to talk to us about the technology itself and what is special about the technology. Sundus.
Good afternoon, everyone. Thank you for having me. So my talk is just a continuation to the whole notion. We went through the indication and the clinical data that support this, but we had multiple technical questions regarding how to perform it, actually. So what is this device? So it's usually a 360 ultrasound technology, okay, to ensure a safe and effective procedure, okay, and proven therapy to lower the patient blood pressure. So this is how it works by ablation modality, treating in a 360 format, at the same time protecting the vessel wall by hydrocooling system to minimize any thermal injury to the vessel wall, with a depth might reach 6 millimeter inside, targeting the sympathetic system. So it penetrates effectively at a target depth of 6 millimeter to ablate the sympathetic nerve around the renal artery, all while staying inside of the lumen without going to the distal branches. So how does it work? You put a wire inside of the renal artery, and then you prepare the vessel. And you can see in the upper corner, it's just 7 seconds. Most of the time, patients need 2 runs in each renal artery, avoiding the ostium of the renal artery, avoiding the distal or at the bifurcation. So 7 seconds, 7 seconds, 14 seconds in the right, 14 seconds on the left, under 28 seconds. So it's very precise. There's no contact, and it's the beauty of it, it has the hydrocooling. So once you're done with the 7, it will just go directly and do like hydrocooling system, circulating the sterile water through the balloon, okay? And then it will deflate automatically, and this is under 2 seconds. The console, as you can see it here, it's very easy, very friendly user. There's like, either you can use the cartridge or the remote, or you can just have a tap on the system by confirming, starting, and then delivering what you need, and it will just keep going, then hydrocooling, deflating, and then you can reposition it. So it's very minimized time. As I said, the whole thing might take under 1 minute in each branch, 7 seconds per cycle. The pain control is very manageable. We still in my center require the anesthesia, and usually we tell them we're gonna now do the sonorization, and then they start giving the patient. It's just 7 seconds. But I have known some cases that they lack the supportive anesthesia, and yet they managed because the duration is very limited, 7 seconds. So it's vein in the mean and renal artery. You don't go to branches. There's no thermal injury, and you have a good depth and no contact energy delivery, as I said, and it's a very safe procedure. As Dr. Fijade has mentioned, safe, very limited, complication, basically related usually either to the contrast or to the puncture. So to answer a question which was raised, like how do you know? We recommend that you might go like, an angiogram with a pigtail to see exactly if there's an accessory, stenosis, or you have a understanding by doing ultrasound or something for the renal arteries. Then you secure a safe access, and then you take a catheter and wire your renal artery. Usually I will go through it in details in the upcoming few minutes. And then you size the renal artery, and that's what you're gonna base your balloon. You have lots of variety of ballooning up to the size of 8. Then you will inflate, as you can see in number 4, and you have like a confirmation of the position. You have a total opacification or occlusion. This is where you wanna be. You go for sonication, 7 seconds, will deflate 1 second, and you hydrocooling for 1 second, deflate, go to the next position. As you can see in number 6, you can have a repetition without an overlap. So let's make it more practical and go for a case. So this is Alive in a Box, which has been done recently with me, with the presence, even my registrars or the interventionist fellow. So number 1, achieve a safe access. Whatever methodology you see fit, ultrasound guided, micropuncture, whatever you see fit, it's okay. Because you don't wanna disturb a good case by a minor problem. Then you start, arranging this stuff. And you can see I'm in the background. I'm not actually doing anything because my fellows now, they're very great and they can do. And that's how a testimony of the safety and the easiness of the procedure. So here we are proceeding because we had some understanding about the size in this case. That's why we started already after achieving access, getting the balloon. And in this case, it was between 5 and 6 go. You can see even the preparation of the balloon for all the interventions is extremely easy. It's not much. You just do some flushing, which is the standard in any preparation for any device in the cath lab. And then you do some connection, which is simple because this is where you're gonna have the hydrocooling system. And the catheter that we put is 8 French guide catheter, length of 55. Usually it depends on where you're coming from, but it can be supplied by your distributor. The wire that you use usually is a bit heavy balance weight wire or Grand Slam, something to give you some support. And then once you have everything in row, you go with the 035 wire with your guide targeting your renal artery. So we started with our left renal. And this is just like, just a recap, how do you do it by the cath? You just make in the catheter, as you can see here, we mentioned it's an 8 French. And then you do your management or your calculation to know what size of balloon you need. 5 or 6 is very variable depending, or sometimes it can reach up to 8. Most of the cases that I have been through so far, the range between 6 and 5 so far. Maybe, I don't know if it's Dr. Muhammad has the same thing, but that's what we have. So now you have the wire there in position. You had a test, everything is good. And then you're gonna just slowly introduce the balloon shortly. This is the preparation of the balloon before introducing it. As I said, make sure everything is good. That's very simple. And then it will just tell you, continue to the procedure. So there's no difficulty or rocket science. It just tells you what to do. So here you go, I'm just like showing, some of the thing, how do you hydrocooling, and then the introduction of the balloon is ongoing now. So here we're positioning the balloon. You have usually a reference below it. We're positioning here. And the second thing, usually we will do what? A confirmatory test that have a complete opacification, and then you start the sonication for 7 seconds, cooling 1 second, then you deflate and you position again in the other one. Usually you go from distal to proximal, as I said, avoiding the edges or the ostium or avoiding the bifurcation. You don't need to go all the branches. It's just. So in this vein, we did 2 runs, and this is the final picture on the left to make sure there's no dissection, no spasm happening. And then we went to the left side now, the right side. So this is what we say. It tells you, verify the position by injection, happy, occlusion, no nothing. Then you will go for the sonication. This is what we call the verifying of the position. And then you go for the sonication, which is 7 seconds. You don't need to do it all the time. You just need to do it like once or twice, that's it. But you don't have to in each position to verify, because if it's occluding distally, most likely it's gonna occlude proximally. But you have to calculate your measurement in each side. You don't have to. But in this case, it was the same size in both sides, so I just needed the same balloon. So another thing, you can use the same balloon in the other kidney, in the other renal artery if needed. So here you go, it's very easy, very simple. My gloves are clean. It tells you that how much it was, simple, straightforward case. I didn't need to really go inside. So here we go, we took everything out. And then final pictures, to make sure your renal artery is good. That's why we're slightly disengaging. And then final part, close the access. Because it's an 8 French, usually we go with a plug-based closure device. But it's very simple, very elegant. If you want another methodology, it's fine. Just final point that I haven't mentioned is ACT. You have to hypertonize your patient during the case, but it's given for any interventional case. So, experience with the power, it maximizes the performance, unlock the efficiency, and deliver lasting outcome. So, efficiency, everyone was very happy. You can see it's like a happy vibe inside of the room, okay? It's very quick, 6 depth, minimal impact, okay? No wall injury or thermal injury. And you stay in the main vessel. You don't have to go the tricky thing, go to each branch and everything. And it's very fewer. You might go to 2 ablations, denervation, per renal artery. And it just takes 7 seconds. It's 28 seconds in both renal most of the time. And that will minimize the patient discomfort and risk during the procedure. So it's very successful. Long-term effects already Dr. Mohammadi has shown it to us. And by that, thank you very much.
Sandus, let me ask you a question.
Yes.
First one. In interventional cardiology, we're always, used to see the result immediately after the procedure. Obviously, this is not the one that you need to have to shift your minds towards long-term results. But, how often have you seen a response sooner than the late anticipated results?
In the patient that I have done in the last few months, usually during it's maybe the sedation, maybe something, but intraoperatively, they come inside with 160, 180, of course, anxiety, but they leave the room with 120, 130. Again, it could be anesthesia. But I have a clinical follow-up with them, and in a month time or 4 weeks, I can see 5 to 10% reduction of whatever baseline they have. Is it by chance? Is it placebo effect? But for sure, within the mark of 4 to 6 months, we see real numbers shifting. And even one of them called me once and said, I'm getting dizzy. Can I stop one of my medications? So we see event, but as you said, in the longer term. But from before they're leaving the cath lab up to 2 months, we have been seeing it. But I cannot this is a personal experience only.
Because, I've seen people on social media talking about immediate response, and one really doubts that, especially that even the sham trials that you showed, there was some reduction. So I think The other thing that goes to my mind is, I mean, this is for the company and for the people in the works, is to develop ways to understand that you have done something to the nerves. You know what I mean? You have done denervation, or maybe that was too proximal or too distal, or did not ablate enough nerves. I mean, these things are, important for operators to see that they have done something, because we don't want to wait until a month or so to see the results.
I echo Dr. Sanders. We see the effect sometimes the next day immediately, but I think based on what we've seen, there is the similar to alcohol septal ablation. There is the triphasic where they dip down, they go up again, and then in 2-3 months they go to the baseline, the new baseline for them. But the dip during the procedure and overnight, it's actually a real thing.
Okay. And the inflation happens automatically from the device. You don't inflate. So it's the saline that comes in, inflates the balloon?
The whole thing, the whole four phases, like,
Yes.
confirming the position,
Yes.
sonivation, hydrocooling, or, deflation, it's all automatic.
Okay.
One press.
That's it. Beautiful.
Have you any question on the technique?
Thank you. Why you choose this technique by record ultrasound? Why you not use by Medtronic? It is easier, 6 French, balloon is lesser. At the end, you need closure at the access site.
So access is not a big issue for me. Has never been, because I work in structural. I work with 16, 25. So access is not even in my calculation. In terms of like why I didn't choose other platform, the honest answer is I don't like pain. I hate it when the patients say, ouch. So that's a personal preference. It's not like, clinical by implemented, but I don't like my patient to suffer or have pain or keep going or prolong the case. So if I have something under 30 seconds and we go out, great. If I have a procedure that even can be done under very simple supervision for the fellows, great. It's repeatable, it's efficient, it's active, and it's been proven. Why not?
Aref, Fahad, you have experience with this technique?
Yes. The answer to your question, Brahim, we are as interventionists, we are impatient. We like to see an immediate effect. So on this technology, we have learned that you have to be patient.
Yeah.
But in fact, since we have started using this technology, we have seen an immediate reduction, but it could be the sedation sometimes. But we do see it. We keep the patient overnight, or we bring them in the morning and discharge them in the evening. Sometimes I get a call from the ward, the fellow, the blood pressure now is 120/80 or 70. Shall we reduce the medication? Here you have to be patient, where you don't reduce any medication, but you have to have a proper follow-up for these patients. As you have seen, the technology is very simple. It's not very complicated. It's 2 cases, the fellow can do it next day. And from the access is no worries as well, because we use ultrasound guided, because we get used to it now. Using the structural, we do closure device, and we have never had any complication from a peripheral point of view. But the key is selecting these patients, screening them, and the follow-up afterwards, because it's very important, because sometimes you get a call after weeks from the patient that their blood pressure is going low. Then you have to start reducing the medication. But I wouldn't encourage reducing it on the same day of the procedure.
In follow-up also regarding the access, I think Ricard is now working on a radial one, so that maybe eliminate the whole thing from the femoral point of view.
Aref, any comment?
Yeah, sure. We have started this technology 2011 from the beginning with the RF, and still I wouldn't go for one toward the other. Still, we are too early to say we prefer this one rather than that one. As also mentioned, pain is there still, both technology having pain. So it's not that one has no pain and the other has pain, but it is less. So we have noticed that that the pain is a little bit, but both are going under sedation. So you have to have usually anesthesia next to you. Some of them now having more guts, doctors. I know a few colleagues now, they are doing only under soft sedation, but you see the patient is twitching even with the new technology that we are discussing today. So both have effect. So we should be aware that we have data about both technologies. We need more data to show which one is superior to the other. We don't know, but we are happy to have a new option. I'm very glad to have something that has less impact with RF, because we are a bit concerned about burning and restenosis. So here in this technology, maybe we are promoting more safety, that you don't have. I remember we did even OCT that time with the RF. We used to see the erosions in the renal arteries. So in this technology, maybe it's not there. Well, we did some imaging, but we didn't see anything. So that is something. Please.
Very skeptical actually about the renal denervation, as you know me. Pain actually was in the past a sign of success, a sign that we like, that you have pain, that we are reaching to the nerve and we are cutting the nerves right now, burning the nerves. That's why pain was a sign of success. Till now, with all the development, we don't have an immediate sign that we did a full denervation. And as we know, just one fiber jumping the renal nerve and went to any branch of the branches that we cannot reach by any technology till today, so will make your procedure failure 100%. So we need to cut the nerve 100%, because if you leave one fiber, and this is proven by the study and by the EEG studies of the nerve conduction, that if you kept any nerve reaching to that kidney, you did nothing.
I may disagree with you, because when we see the data being presented, something happened, and we have seen clinically, we have seen. So it is not just the data. Even with our experience over 12, 14 years of doing this kind of thing, we have patients responders, we have non-responder, we have mild, moderate responder. It's all there. We need to understand this technology more, but we can't say that you have to do 100% denervation to show evidence. No, I don't have any data to show this, and we don't have that. But what we are doing, that means we are achieving, if we achieve 80%, 90% of denervation, the impulse or the signals that you are reducing by this technology apparently has an impact. Otherwise, you wouldn't have seen this kind of reduction in the blood pressure. And we have experience, we've seen patients coming now where they were 4 drugs and now they are on 1 single drug, and that's really fact, we see it. So I can't agree that it has to be 100% sympathectomy, or like we do radical sympathectomy like before we used to do. But so that's my opinion. Thank you.
The data actually behind renal denervation, decreasing the blood pressure, it is not new. This is we have seen 14 years ago when we have started before. I did it 14 years ago, the renal denervation, and we kept doing it for 4 or 5 years because of the data and the studies, and that even two of them I have participated in that studies. The clinical data, the reduction in the blood pressure, systolic and diastolic, was there. After sham trial, all of this fell down. Now, what really we want is really to show new data that is different than 10 years ago of reduction of renal denervation. The reduction is the same. It is not more than before, maybe more sustainable. We have longer studies. But the point is this reduction that related to renal denervation, it is sometimes not due to the renal denervation itself, because the patient changed his behavior. And really for the patients that you have, Dr. Mohammadi did for her redo, what is her height and weight at the first procedure, and her height and weight in the second?
Dr. Raad, thank you so much. Thanks for the point you mentioned.
Sorry, that's the patient changed the behavior. I don't believe that. I don't believe after PCI. I don't believe after bypass surgery. I don't believe after valvular disease. You cannot say that. And for all of you, no, you are not convinced by the technology either. But for all of you, if you have the guidelines and if you have the reimbursement, I can tell you that this is coming from a meeting of people who knows expert, and meeting from expert, and these experts say, okay, now definitely it works. If not, you have not the guidelines. If not, I can tell you in Europe, we have no reimbursement. No. The problem is you have not the same effect. I don't defend this technology, it's not a problem. But again, when you have a guideline, and second, more than the guideline, a reimbursement by the national insurance, I can tell you that there is no discussion. This is not coming from one guy, it's coming from, a lot of meetings. So, no, but it's, for me, it's clear. We need to move to
the point is clear.
We could discuss later.
John has mentioned, and we need to move. We keep the questions. Dr. Ahmed Imam, a colleague from Kuwait, he will tell us the future of ultrasound RDN.
Yeah. I came from future, right? It works. Don't worry. I'm from future. So I'll speak about the future of renal denervation, what will we have in the coming years. So we know hypertension is remain, as Dr. Muhammad said, a global health challenge affecting more than 1.3 billion worldwide, and this is contributing, of course, in the majority of cardiovascular morbidities. And large portions of hypertensive patients, despite the advances in pharmacology and in the drugs, remain uncontrolled, and this is mainly due to drug non-adherence. This gaps leads to the interest in the renal denervation as a durable, well-validated, and always-on effect, directly affecting the sympathetic overactivity. In the past, we are doing the surgical sympathectomy as an option for treating resistant hypertension. But now, in these days, we are standing in a pivotal moment because future of renal denervation is really expanding beyond only treating hypertension. We can extend its use for a new indication like CKD, heart failure with preserved ejection fraction and atrial fibrillation, and any other condition linked to the sympathetic dysregulation. There is a vision and program from Paradise and Recall Medical just to deliver the best in the class ultrasound denervation technology, and this include how to optimize the procedure itself and the device itself, and delivering the radial access catheter into the market, besides supporting and funding the research in the market just to get this advance into clinical practice. When we are speaking about how to optimize the procedure and device more, it's about the simplify the procedure. Maybe they are working now on a single balloon to fit various sizes of the vessel, so one balloon fits all sizes, and also to improve the generator feature to improve the user experience and make it easier for the physicians. Of course, radial access catheter, I think they are working now on it also to improve the renal denervation experience, less bleeding with the next generation renal catheters. Expanding the new indication beyond hypertension alone, we have now promising data is now for kidney disease, either stage 3 CKD, polycystic kidney disease, and even in the stage renal disease, also with the diseases with the high sympathetic overactivity like anxiety, sleep apnea, women in the planning pregnancy, with sympathetic overactivity plays a major role in those population. In the cardiology, the heart failure and arrhythmia heart failure also decrease the sympathetic overdrive may help to improve the outcome in those population. So going through the patient with CKD, we know high blood pressure is not only extremely common, but the problem, high blood pressure can damage the kidney. There is like 850 million globally with CKD due to hypertension. And it's not easy to control blood pressure in those type of population. 40% of CKD patient has resistant hypertension. But now, fortunately, we have growing evidence renal denervation, it's effective in those population. There is a nice meta-analysis 2021 showing promising data to treating this population with renal denervation. Record position and role in this trial and meta-analysis to support the program itself without real influencing the data or controlling the results. We have I'll show you some results and some study already published data. This is a study called RDN CKD studies published in Journal of American Society of Nephrology this year, 2025, to assess the blood pressure reduction after ultrasound renal denervation in patient with CKD type 3, and the results showed a significant reduction on those type of population. Another study also for another group of renal patient with polycystic kidney disease, and also the result is positive with clear reduction of systolic and diastolic blood pressure without any safety concern in those populations. So together, this study in the population with CKD providing a growing evidence that ultrasound renal denervation is effective and safe across different CKD population. Moving now to another population, we know the sympathetic drive is high in those population. Patients with anxiety and sleep apnea, we know they have overactive sympathetic activity. Women planning pregnancy, blood pressure drugs is not safe in those populations. So maybe there is a rule for renal denervation in those type of population. Still, the trial is ongoing. We have a sham trial for patients with anxiety and sleep apnea, waiting for the result to be presented maybe in the next year. Also, we have one French trial. It's called YRDN. It's expecting the result also by next year. Moving for the cardiology indication, we have patient with heart failure with preserved ejection fraction, because we know there is no definite drugs or treatment for those type of population, but renal denervation may be the answer for those type of population. Recall also is supporting this research without active influence in the results and in the patient itself. The study, it's still ongoing. It's called Unload Heart Failure or Unload HPF, which is kind of sophisticated trial. Patients under Swan Ganz, sometimes they are putting cardiomems inside the patient just to follow their filling pressures and everything, and expecting the result by next year. For the atrial fibrillation, we know heart failure are increase the risk of AF in those populations, and there is low success of AF procedure. 1 in 3 patients require more than one procedure, so the result is not that good as much. And also we have supporting evidence currently. This is a meta-analysis. It's there with 711 patients showing there is significant lower rate of atrial fibrillation recurrence if you compare between pulmonary vein isolation plus renal denervation versus pulmonary vein isolation only, as you can see here in the down corner of my slide. And again, record only supporting the result without controlling the patient itself. This is also 2 trials, one already published on the left, and in the right it's ongoing. On the left, it's called Ultra-HFib, which done on the patients going for atrial fibrillation ablation. And the conclusion, it's a pilot study. The conclusion, it's non-significant, but at least it shows us there is a safety, and the recurrence is less by 35%, but it's not significant. Waiting for more research and more evidences. The result, the study on the right side, it's a AF redo. It's ongoing, and we are waiting for the result. It's investigating patients for redo ablation with renal denervation. So my take-home message that renal denervation is evolving now from the hypertension-only therapy to a broader autonomic modulation tool or therapy. Next generation catheter, we are waiting to simplify our workflow and improve safety, precision, and operator adoption. Evidence is there, and it's still growing, including CKD, HFpEF, arrhythmia, and sleep apnea. So RDN is now positioned to become integrated component of the long-term cardiovascular and renal disease management. Thank you very much for your attention.
Dr. Ahmed, questions for Dr. Ahmed? Please. Let me throw you the... Okay. There you go. Oops.
Dr. Ahmed, thank you for your presentation. Do you think it is a multi-organ denervation in the future, or it is only renal? Do we see part of the picture from the bigger picture? Because we heard from the European Intervention Journal recently, preclinical studies showed common hepatic vein denervation also maybe play a role in
hepatic artery, I think.
Hepatic artery, yeah,
yes.
You are true.
Yes, there work now on this for simultaneous, not simultaneous, in the same setting ablation of the renal artery and renal hepatic artery also, just to treat like metabolic syndrome and to treat patient with diabetes, for example, and patient with increased sympathetic drive. There is a study is ongoing now, ablation the hepatic artery, duodenum arteries going to the duodenum, to the spleen also. So as you said, it's now moving from renal artery to multi-organ ablation. Now there is ongoing trials now.
Disconnect the brain from the body.
Yes, yes, yes.
Actually, we had also recent experience with pulmonary artery hypertension ablation.
Yes.
Patients, we did 3 cases. There was 2 good responder, dropping the pulmonary pressure nicely. Thank you.
Yes.
Yes, sir.
Thank you, Doctor. Just I ask about, you mentioned in the slides about estimated GFR and CKD level, 30 estimated GFR you do renal denervation. I think it is a class recommendation, estimated GFR 40 and more. What about 30 to 40 could be borderline or carry some caution?
Exactly. I agree. Now the recommendation we have is to ablate patients more than 40 to 45 GFR. For patient with end stage or stage 3, for end stage, you can ablate because there is no kidney is already gone, so you can ablate. The issue with patient with CKD grade 3 regarding the contrast, how you can manage your contrast, maybe go little contrast. CO2 is also an option now, as mentioned here. But still now, the recommendation above 45, this is still under investigation.
Yeah. Other question?
So much for the nice presentation. I just wanted to ask about your experience with another modality of treatment that acts like a sympathectomy. It's called a celiac plexus block. Has any of the panelists used it? I have a patient two patients actually, who we tried renal denervation with maximum medical therapy and it didn't work. I sent them for a celiac plexus block. The celiac plexus contains a lot of ganglions and catecholamines, which when you block it, sometimes reduces the blood pressure. So we blocked it using one case Botox and the other case dehydrated alcohol. I wanted to hear of any experience in the panelists. The result was great for my patients.
How do you do that procedure?
It's the same as cancer patients when they get very severe abdominal pain.
Yeah.
They go to the anesthetist and they go to the...
Okay, they block it.
They block the
directly.
celiac plexus, which contains a lot of norepinephrine, dopamine, and others. Just wanted to ask about this modality of treatment.
Okay.
Anybody had experience with this thing? So you're the expert in the room.
Yeah.
Personally, no experience.
If no other questions, we have 1 minute. We need to maybe wrap up. Thank you very much. I think we had a fantastic session. It was a great session. We started with Dr. Mohammed Al-Mohammadi, who laid the foundation, all the evidence, discussed the evidence, including the sham control studies, which was convincing to get into the guidelines to recommend it as class 2B. Then went to Dr. Sundus, who explained to us how simple this technology is to perform in a cath lab through the femoral axis, future through the radial axis, as Ahmed had said. And Ahmed had showed us what the future is holding in terms of different device. So one balloon serves all the patients categories, radial axis, and different indications, including AF, as I learned from my colleagues here, heart failure, HFpEF, CKD, then you name it. Obviously, we need for trials to convince us that these are working in these, but for blood pressure, you have it. Thank you very much. You've been a great audience, and see you in another session.